Good afternoon, everyone, and welcome to the report out for RPIW number 18, which is the level 5 discharge process. My name is Michelle Hart-Suter, and I'm the team leader for this project. I'm a nursing unit manager in long-term care at the Bassett home when I am not doing this. My team will introduce themselves as they present, and we'll be reporting to a tack time of 20 minutes. We are the good to goes. The reflection of our focus to have discharges good to go by 11 o'clock. Our project form shows who we are, who helped us along the way, and the theme of our project, which is to increase the number of discharges that are ready to go by 11 with completed packages faxed to home care. It's really important to address this RPIW, although I know there's been some work done around discharges before. It's still really important to address because we do have people waiting for beds that are acutely ill. We do have nurses and other care team members that are providing care in the hallways. We are at overcapacity often, and we do have surgeries that are being canceled because beds are not available. So very important to address this RPIW. We did build on the work done in RPIW 7 in order to identify issues with preventing successful discharges on time. And this included the use of the D- system and communications regarding the completion of the discharge package to ensure patients' needs were met. Next. Our value stream map shows the process that we followed, which was receiving the doctor's orders all the way to the discharge package being completed and faxed to home care. The starbursts that you see at the top were ideas about improvements that could potentially be made in order to add more value to the process. If you can look up in the right-hand corner, you'll see our value-added time was 15 minutes, 40 seconds. Our non-value-added time was 22 minutes, 20 seconds, with the entire process taking 38 minutes. Okay. Our calculations for tack time is to show really what's available in a day. How many minutes do you have a day to perform the work that you're doing? For the processes of this, we did the calculation, but it was more based on an average of 2 discharges per day, and we don't assume that that's all the PCCs are doing is 2 discharges per day. Okay. Our target progress report sheet shows our baseline of where we were at before and our target of where we wanted to be by the end of the RPIW. So it talks about different things as far as waste in the system, whether it be waste of inventory, items on hand, whether it be waste of space, walking distance. The lead time, which was 38 minutes, we wanted to cut that down by half and achieve a lead time of 19 minutes getting that package faxed to home care. Okay. Our time observation form is the steps from the time we receive the doctor's order to the time the package is faxed, and it also includes all our waits and walks in between. So we did a mock-up because we didn't have the discharge right away when we started, so we did a mock-up and we followed Patty through the process of the discharge, and it was 38 minutes. Following that, we did several other actual timed observations of discharges, and they were very close to that same 38 minutes, so the mock-up was quite accurate. Following the RPIW, we were able to observe discharge, and the time went from 38 minutes lead time to a lead time of 7 minutes, 35 seconds. So substantial gains were recognized there. Okay. Our standard combination worksheet, again, goes through the steps of the process and shows the value-added time, the time spent waiting, which is signified by the double bar line there, and then the time spent working, the time spent walking. You can see it's been cut down by a significant amount. Our percent load bar chart shows the different cycle times, so the pieces of the lead time that were actually work time by Patty, the PCC, patient care coordinator, and so you can see what it was pre-Kaizen and then post-Kaizen, much less. Time spent.
Hi, I'm Marge Jurgens. I'm a family physician, and I'll be speaking to you about waste. And for those of you who are familiar, you can see on the upper our waste field that was achieved by looking at level 5 board prior to doing our process. The bottom half shows you the post-Kaizen with all the issues that we could possibly address. We found that a good portion of waste time was time people were looking for and could be solved with better communication. So there's kind of 3 things that we sort of worked on to improve communication. One is improving the PSAG board, and Brenda will be speaking to that issue. 2 is doing a multidisciplinary checkout list that Colleen will speak more to. This is new initiative. The actual list, as well as a communique from Dr. Reupen and Hookinson, have been sent to the physicians. I did have some time to spend with the physicians and the conversations relating to the targeted date of discharge, as well as this list led to many more ideas for future projects. The 3rd suggestion that has been implemented already is doing daily mini rounds. Secondary, a major concern with respect to waste is, I'm not sure how you label it, but use of beds for patients who perhaps could be better cared for in other locations. And this relates to patients who are awaiting long-term care assessment or have already been assessed and haven't been placed. So it's really impossible for physicians to do a targeted date of discharge on a group palliative care. 6 of the 34 beds are not occupied by palliative care. 16 of the 34 are occupied by patients who have actually been requested for assessment or assessed. 2 of them have been assessed. Of the remaining 4 have less than 1 month of lead time. That means that the request for assessment has been longer than 1 month to go in the majority of these people. 1 patient has waited 9 months for assessment. So, suggestions for changes beyond this, for communication purposes to be best achieved. Paper isn't always the best way. A charge nurse or a desk nurse would be ideal Monday to Friday during the workday, and then a better way of assessing long-term care and achieving placement of not possible without other things being done. Thank you.
Hi, I'm Patty Bergen. I am one of the patient care coordinators on level 5. As you can see here, we've completed a few spaghetti diagrams. This one in particular is regarding obtaining referral forms. Historically, PCCs would have to keep photocopies and rely on one another, possibly going from floor to floor to retrieve forms if there wasn't a significant amount within our offices. Now, with the next spaghetti diagram, and that shows 264 feet going from floor to floor. Now with this spaghetti diagram, it's 51 feet because we've now put on our desktops. The next spaghetti diagram is regarding some of the wait times, waiting on the multidisciplinary team to sign off on the charts, tracking down some team members to ensure that everything is in order to send out our referrals to the referring agencies. This would take roughly about 320 feet. So now with our multidisciplinary checklist, it's now reduced to 49.5 feet. Up next here we've created an idea summary sheet regarding some concerns with brochures and pamphlets. As PCCs, we need a lot of resources for our patients and families, and would keep a few on hand in our offices. It would become an issue because if we ran out, we'd have to go from office to office, or even down, as you see on the spaghetti diagram, right down to the PCC trailer room, which would be 900 feet. Now we have put in a brochure holder up in the office, which is now 2 feet to access brochures. Up here is the work standard, which we've revised from the RPIW number 8, the completing of a home care referral form. We had an idea summary sheet regarding referral forms, how to complete them properly to send to the referring agencies, such as home care for home care nursing or home services. In our unit, we didn't have any standard work for that, so we've created 2 standard works in that area. And with that being said, we are using our multiple skill training checklist to educate all staff on that.
Hi, my name is Colleen Eddles. I'm an occupational therapist. I work in inpatient and home care. We had an idea summary sheet around creating a multidisciplinary communication tool for a discharge checklist. This is it here. And so that checklist would be initiated once patients were D-3 or less. It also will accompany those mini rounds that are happening every day. It'll be placed in a chart once it's initiated opposite the doctor's order, so it's open and easy to find. And basically any discipline can identify orders or activities that might be needed to ensure that discharge is organized for the D, for the day of. And once it is completed, then it would be checked off. Next. So we did create some work standard around that because it's a brand new form and a brand new process. Next. And we did some education has begun around that to all the affected multidisciplines. We also created or revamped some work standard around the nurse-to-nurse referral. So that will be started by the evening nurses so that it's completed in a timely fashion, not holding up discharge. And that's just showing our training that's begun with that. We also made some slight changes to our current therapy sign-off process. We created some work standard, and that's just showing the education rollout for that piece of information.
Hi, I'm Brenda from level 5. I'm a nurse on 5, and I'm just going to briefly talk to you guys about our PSAG board, or our patient status compliance board. So that's our 3 Kaizen picture of our boards. The boards were originally designed to be a communication tool so that if a physician, a nurse, or other staff members are coming up to the floor to look at the boards to get information about their patients, they can take a quick glance at the board and get the current updated information. But we noted that the boards are not always up to date every day. So we did come up with a couple of idea summary sheets to help us out with that. The first one is about our rounds that happen on level 5. There's 3 times a week currently, and we've been trialing this week every day this week, so 5 days to have rounds so that we can try to keep our boards updated. Secondly, we have kind of reintroduced our legend, or our key for the PSAG boards. And that's just a little overview of our key. Now our post Kaizen picture here, and there is a nice picture of a couple of our happy nurses on level 5. So that's just an overview of our kind of revamped boards, and much more organized looking. We've made our legend bigger and posted that above the board so that everyone can see that at a glance as well. And most importantly, our boards the information is there and updated. We've also created work standards to teach everyone how to use the boards, and education's being rolled out. And we have a multiple skill training checklist for the staff.
Hi, my name is Yan Lai. I'm the Regional Director of Medical Imaging. So what we have here is pre-Kaizen forms that we had for the home care assessment. Okay, here's another pre-Kaizen. So, okay, and then we had an idea to make the forms electronic, and here's the idea sheet. And we made them electronic, and you can see here on the post Kaizen form, the urgent request was made so that we can see it better. And then over down here in the infection controller, that was added. And for the services, that was nice and clean. We basically cleaned it up and we saved it on their desktop. So HPCC will have these forms on the desk. You can print. And then on this form, you can see that the patient care, patient history, it's all nice and clean and saved electronic form. Then we had an idea to take their fax cover sheet and make it more personal for them and easier for them to use because they were using the standard one. So you can see that each PCC has the fax cover sheet on their desktop, and it have their name and phone number and fax number already. So it's easier for them to transmit. They just check off what they need to send it and put the total page and date is done. Then, as we were up on the level, we noticed that another idea that happened was that there was no signage to show the patient where to go, where the reception desk was. So we created some signs. When you come off the patient elevator, you would see the reception desk go that way. And we have these signs right here. They're pointing to where the desk is, and you can see it from the hall. Thanks.
Good afternoon, my name is Gord Hine. I work in the Acute Care Access Program Patient Care Coordinating Unit. We had a idea summary sheet about patients not being aware of discharge time, so we installed signs in every room so that people are aware that discharge time is 11 o'clock. And we also talked about communication being essential, so we wanted to trial some whiteboards, patient boards in each room, so that it allows the patient to know exactly where they are, what day it is. It also allows staff and family to be aware of any special restrictions and so on. And the targeted date of discharge is on there as well. So there's a room at the bottom for them to see later that there's a way to explain or have comments. So we'll see that as we go along. This must have been Clark Kent's room because he's the only one that could read the sign behind there. So it was there, but we just couldn't tell what time we're supposed to go. So we removed that, and this is how it looks now. We have the patient discharge time very bold, and people can read it from across the room. And below it is the patient communication board. So at the top, we have the patient's name for confidentiality, put it out. So now we have the room number, they know the current date, they know the date of discharge. We've left lots of room for the nurses because they do team nursing on level 5. Then they also have restrictions on diets and so on. And at the bottom, there's a large section for comments from family or questions that can be addressed by staff on a daily basis. And we created some work standard here as well, so that the nurses that are involved with the care will be providing that up-to-date information on the whiteboard. And then we rolled it out for the education on the floor. Thank you.
Hello everyone, my name is Tina Pohl, the happy volunteer from the Volunteer Services. RPIW number 18 targeted the dirty service room on level 5 for their 5S makeover. The eager team of Donna, Jan, and myself began sorting all things obsolete, expired, or just not needed. We removed shelves too high for safety and lowered others for easier reach by staff. Information posters like the biohazard, for example, were moved to visible areas or totally replaced with new printing. The commode liners and bedpans were neatly grouped with proper labeling plus reorder number for quick reference. All remaining shelf items, freestanding equipment were separated, labeled, and clutter eliminated. Commodes were neatly stored with proper floor markings in place. Standard work forms were created, and the staff training has commenced. This room started with an inspection rating of 1 out of 5. And we finished with a sparkling mark of 3. 64 waste items were removed, including a shiny metal bedpan. Staff will surely enjoy the fresh look of this much utilized room. As Gord mentioned, whiteboards are now added to patient rooms containing pertinent information, including expected discharge date. I visited several patients to get their reaction and can happily report that all thought the whiteboard is a good idea. Some remarked, now they know what date it is, and others felt good seeing the name of their nurse. As a patient, knowing the new discharge checklist is in use, I have peace of mind that plans will go well with my move, my required medications, and information on my discharge. I believe improving the discharge process is all for the better and wish Level 5 much success.
Good afternoon, I'm Terry Field. I am the sub-team lead, and next week I return to my real job as Regional Director Environmental Services. As you will notice on the post-value stream map, that we were able to eliminate quite a few of the starbursts. I'd also like to point out, as Michelle had mentioned, that our lead time we were able to reduce from 38 minutes down to 7 minutes 35 seconds. And our value added time we were able to increase to 96.7%. Very proud of those numbers. In the target progress report, lots of the gains have been mentioned already about the park travel and walking distances. But what I'd like to point out is the lead time, that we were able to reduce the lead time by 80%. Also, in quality, the PSAG board, the defects, we were able to have 100% reduction. Next. The next one is productivity gain we would like to brag about. We've had productivity gain of 306%. Huge, huge numbers we're very proud of. In our newspaper, we did lots of work this week. We left 4 items only on the newspaper and all have been started. We are very confident that they will be completed by the end of May, which is we have given as our deadline. For our workshop summary, patients are the reason that we're here. Everything that we do, every improvement that we make, every efficiency that we gain, free us up to spend more time with our patients, which is really why we are all here. And you can read the rest, but for us as well, another very crucial learning was communicate, communicate, communicate. Don't assume you know what anybody wants if you're creating forms and that. Talk to everybody, bring everybody in. If they're also included, we also feel that you will achieve way more buy-in.
This is our thank you page. I don't know if you can see the whole thing. I hope you can. We're indebted to all of these people that I want to especially thank Donna from our KPO and Deb and Sensei Narita from John Black & Associates for their direction and guidance during the RPIW. I wanted to thank Monica Harper and Tanis Johnson for hosting us and being open to the changes and really helping to facilitate everything that's going to help us achieve the results that we're looking for. I want to especially thank Tina for being our voice of the patient, because that's why we're here, and thank my team because they really have the patient's best interest at the center of everything we were doing. Whenever we started to go off on a tangent or lose focus, they would bring it back and we'd say, okay, how's this going to affect the patient? What's best for the patient? So I really want to thank them. The level 5 staff and the patients were great for letting us invade their space and participate and let us ask numerous questions in order to get to the point where we did today. So thank you very much.